like to spend a few minutes sharing some background about readiness and preparing for participation in a curative therapy, gene therapy trial, and then finish with some of the details about the particular project that we introduced in the video with Brooklyn Haynes. So, sickle cell disease, as the video introduced, is a disorder that affects virtually every organ in the body, and that's because it can adversely affect the flow of fluids, nutrients, and red blood cells to those organs. And the hallmark is pain, which is caused by the disruption of blood flow to bones and muscle, where a painful stimulus can be elicited. But virtually every organ, as I mentioned, in the body can be affected, as depicted here. And together, the damage to the organ and is cumulative and shortens lifespan, but also the quality of life and the unpredictability of the painful episodes. It can impair the quality of life significantly as well. And the quantity of life, which is shown in this particular graph, a recent experience, which is illustrated by this Kaplan-Meier probability curve, where on the y-axis here is percentage, and then on the x-axis here is the years of age. And this is a group of adults who received care at Vanderbilt and University of North Carolina on the East Coast. And the curve begins at 20 years of age, where all of the children who are now adults are transitioned to this adult program. And what's interesting about it is this incredible disparity in lifespan. So the average lifespan varies from the upper 40s to mid 50s, depending on the particular genotype that's inherited. It represents a 30-year decrement in lifespan compared to African Americans who don't inherit sickle cell disease. So right away, there's a disparity in which Marcia Treadwell correctly assigns to problems with a disparity in research dollars, in access to healthcare, and structural racism. So when we consider, when we meet with a family or a particular individual who's interested in a curative therapy, begins with a clear and hopefully transparent discussion of the clinical benefits, that is living without sickle cell disease, and the risks involved with getting to that destination. And so first we try to identify who might most benefit from transplant. They tend to be persons who are already having significant complications of the underlying disease. And we ask this question of, should we transplant now, either before or after the complications have occurred, which is often tailored by the clinical trial that we're considering. And how do we consider a curative therapy in terms of its clinical benefit in the context of now having newer supportive disease-modifying therapies available that are recently FDA approved? The risk assessment is personalized. So what risks is a particular individual willing to accept, and how do the sickle cell disease-related comorbidities, that is existing organ damage, affect whether or not a particular risk will occur? And then is there adequate psychosocial support, which is also a key component to making a decision about whether to offer and whether to pursue curative therapy. And so the decision is often organized in this type of way. It might begin with evaluations for organ damage, and we focus in particular on the heart, lungs, kidney, liver, and in the central nervous system. And there are ways for us to do that with clinical screening. We also have to be cognizant and supportive of the pain management program that the patient brings to the particular curative therapy, and how might we expand or modify this in a way that will support them through the curative therapy. Have they already instituted optimized disease modification therapies? And sometimes we use these in preparation for the curative therapy. And then again, terribly important is this psychosocial evaluation. Is there adequate transportation to the clinic and the hospital? Is there access to pharmacy? Is there a caretaker who's willing to assist 24/7 in the recovery period? And what are the financial issues? Is there suitable support to get through this safely, or will the treatment cause financial harm and therefore not really be suitable for pursuing? And finally, we have to be able to give red blood cell and other transfusions to get through transplant safely. So we often do a screen to make sure that we can accomplish that, and other evaluations as well. So that's some background around the considerations that go into introducing patient and their family to the possibility of participating in a curative therapy trial. And I'm just going to spend the rest of this talk showing some of the preclinical work that we've done in preparation for applying the CRISPR technology to sickle cell disease. So why even consider this if we already have a curative treatment, which is a bone marrow transplant from a well-matched brother or sister as the donor? Well, as it turns out, only 18% of the families who we meet will have a child or an adult with a HLA identical sibling donor. And when we do an unrelated donor search looking for a volunteer who might be willing to donate their bone marrow if their HLA type, if their transplant type matches up, we can only increase that by another 19%. So even if I wanted to treat everyone who came to me wishing to have a bone marrow transplant, I could only do so about a third of the time. And moreover, the treatment itself carries risks. There's a complication called graft versus host disease, where the immune system of the donor attacks the recipient's body in the same way it might attack a germ. So that can cause a risk of dying. And clinicians and participants considering this kind of treatment often decline because of these risks. And so until recently, transplant has been largely restricted to children, and even there, applied very sparingly. So if we can't find donors, can we modify a person's own autologous cells for clinical benefit? And that's the question we're asking with the CRISPR technology. And then if we're able to do that, this needs to go hand in hand. In parallel, can we ensure, if we establish a curative benefit that's now broadly available, can we ensure access that's equitable to the novel curative therapy? And the NASAM took on this question and came up in this 2020 publication with some interesting recommendations. So first, they thought that that the gene therapy approaches, including CRISPR technology, should involve shared decision making for patients considering the novel therapies, and the HHS should encourage and reimburse this practice of shared decision making. And then, in addition, to go through the clinical therapy and the medical treatment, that the Centers for Medicare and Medicaid Services, CMS, and state Medicaid programs should explore novel payment models that encourage and pay for coordinated care through developing and then instituting and offering the cost of curative therapies. So this is a novel approach, and one that I think would help us pursue this both more aggressively and more broadly. So what are the patients saying about these new therapies? And this is a recent publication, and I captured some of the statements. So one patient said, "I'd never allow it to happen, being leery of bone marrow transplant because and wouldn't consider an option to me, or I don't want no bone marrow transplant because you could die from it." And then one parent said about her son, he's getting to the point where he's kind of sick of the pain. He wants to do a bone marrow transplant at some point. Without knowing that it's going to be 100% successful, then I would only choose it if I had to. But that's if other options failed, like hydroxyurea wasn't working, and he was very, very sick, and blood transfusions were just starting to take over his whole life. So here, that's one end of the spectrum. Another thing to consider, its risk could be like exchanging something you know versus something you don't know. One participant expressed concern that if you don't want to get rid of sickle cell disease and end up with something worse. And then finally, another patient said, "I'm all for it if there's some strong risks to it, and it's not the easiest process, but I mean, I believe it's still better. It's a great opportunity for patients with sickle cell." And another adult patient highlighted the risk of mortality with sickle cell disease itself, saying, "Even if it's about BMT, life-threatening, I would take the chance, because either way it goes, living with sickle cell, eventually it is life-threatening." So these are just some of the views, pro and con, that need to be aired out in considering participation in these kind of trials. And the goal that we're pursuing is this so-called ideal cell therapy profile, which would protect from the sickle cell disease related complications, both the symptoms and the subclinical damage to the vital organs, display an acceptable toxicity profile both in the short and long term. It should be accessible and available to most patients, safe in children and adults, and rely on a comparative clinical trial design that shows benefit curative therapy compared with the existing disease modifying therapies, both in the short term and long term. So one of the risks that came to the fore in the last year and a half or so were these two observations of acute myelogenous leukemia that occurred in 2 participants among 43 who received an lentiviral gene therapy drug product. So these were cells that were modified in a way, stem cells, to make an anti-sickling hemoglobin. And 3 to 5 years after the treatment, and these were 2 of the first patients enrolled, they developed acute myelogenous leukemia that developed as a consequence of these driver mutations that we know can cause or amplify the AML initiating event. In one case, the leukemia cells had no lentiviral vector in them, so this is the first case. And this case was judged a consequence of receiving the high-dose chemotherapy as a leukemogenic agent in preparation for the treatment. But in the second patient, the vector, the lentiviral vector, was present in the leukemia cells, but it integrated near a gene that doesn't cause leukemia called VAMP4. So in both cases, it's possible that the treatment, in ways that we might or might not understand, appeared to accelerate and amplify this risk of developing acute myelogenous leukemia. So it's something we need to be aware of as we plan and design our own CRISPR trial in the future. So I begin with a description of the reagents that were developed. So depicted here is the single-stranded DNA oligonucleotide that has the corrected template from which a healthy copy of the beta globin gene would be produced. And in red, the sequence where the guide RNA brings that nuclease, the Cas9 enzyme that makes the double-stranded cut at this red triangle. And from this location extends the strand so that when it reaches the sickle cell disease causing valine amino acid, it changes it back to glutamic acid. And once this reaction has occurred, we change the sequence also so that the enzymes can't cut the DNA again after the correction has occurred. But I just show these details because I'll refer back to them a bit later. And this reaction isn't going to correct every sickle cell mutation in every stem cell, but our experience in bone marrow transplant, that is using a healthy donor to cure the disease, showed that some of the time mixed donor host hematopoietic chimerism develops. And in fact, with as few as 20% of the healthy donor's blood cells growing in the bone marrow, that's sufficient to cure sickle cell disease. And this phenomenon occurs because those healthy, healthy normal donor erythrocytes have a normal lifespan, and they outlast the sickle cell disease blood cells in circulation. So based on this observation that's very significant, if we can correct at least one sickle mutation in 20% of the engrafted stem cells, we should have a curative effect. And in fact, that's what we've been observing. These are 2 manufacturing runs that were conducted by the team at UCLA. And after we put the human cells in the mouse and then collected the bone marrow, 20 weeks later, we were able to count the number of stem cells that form a colony in an in vitro test. And when we do the DNA sequence, we observe that 40% of the colonies have, so these are 40% of the stem cells, have at least one copy of the corrected allele, with the remainder either being uncorrected, that is unmodified, still sickle cell disease in green, or, and this is an interesting problem that we'll have to overcome, in another 30% of the time, we've introduced, after correcting the double-stranded break in the DNA, a new mutation that causes thalassemia, which is a genotype that doesn't produce any beta globin. So, but because 40% of the stem cells are corrected, these would be dominant and should lead to a curative outcome. And in fact, the team at UCLA, led by Don Cohn, has now run 6 manufacturing runs using the optimized protocol for the gene editing procedure, 3 small scale runs in sickle cell disease, stem cells, and 3 clinical scale from healthy adult volunteers who gave a clinical dose of stem cells. And these cells, after the manufacturing, pass the release criteria. They would be suitable to use in the clinical trial. And our average correction occurs 26% of the time, which is above our threshold for what we predict would be a cure. But there's still this problem that I've highlighted here of the insertion deletion. So these are going to be thalassemia containing alleles that must be balanced by a sufficient number of corrected alleles. So this is one of the critical observations we'll need to make in the trial, and that we'll have to disclose to participants in the trial. So it begins with a procedure to collect the stem cells from the bloodstream. In the laboratory, we isolate the stem cells, we introduce the gene editing reagents, and then those cells are frozen, and if they meet the release criteria, they're shipped to the transplant center for thawing and infusion. And this is a picture of the GMP lab personnel at UCLA. And so, and another depiction is beginning with the patient. We do the stem cell harvest. We ship the cells to UCLA, where they undergo this electroporation, where the gene editing reagents are introduced into the stem cells. Once they're edited, they're frozen, and then we'll give the patients high-dose chemotherapy to destroy the sickle-producing blood cells in the body and replace those with these gene-edited modified stem cells given in the same way as a blood transfusion. They'll migrate to the bone marrow and hopefully over time take over blood production and elimination of the sickle cell disease. So we successfully filed for an IND a year and a half ago. We procured funding that was released in December 2021. Our first patient will probably enroll not this year, but early next year. And then we're following a staggered enrollment so that a data safety monitoring board will review results after the first 3 patients and then after the first 6 patients. So we'll probably begin a pediatric enrollment in 2024. So in summary, patients, families, and referring physicians have concerns about myeloablation, in particular the risk of developing leukemia from these therapies that must be mitigated and disclosed. We don't yet have any experience with the long-term effects of these gene modification treatments. There was a patient with another blood disease called thalassemia who had been free of red cell transfusions but resumed them 10 years after the treatment. That's something that we'll need to monitor. Is there a risk of developing what we call clonal hematopoiesis, which is a precursor of leukemia? And we don't yet have long-term safety information that we'll need to gather. And finally, maybe most importantly, will the cost and complexity of this treatment restrict access to care? So we're asking now the question: how do we ensure broad availability versus limited availability in a small number of centers? So those are some of the considerations I wanted to share today, and thank you for your attention.